on.
All right, so I will try to skim over and not go into too much detail. Again, if anyone has any questions, feel free to interrupt at any time. Also, I chose hamstring and calf strains because I have an absolute love for it. Oh, and it was the last option when the list came out over a year ago. So I just thought I'd take that on. I'd let everyone else choose. So first off, I will go with, oh, come on. All right, I thought one thing I was curious about was just even where the word hamstring came from. I had misunderstood where it came from, and I thought it actually came from hanging meat, but the word ham is an Old English word, just meaning the hollow behind the knee, and string referring to ligament, tendon. And so hamstring, its function largely extend hip, flex knee, decelerate as well. And if you just look at where they attach at the knee, they're going to help with rotation as well of the tibia. Calf, a few people have asked, believe it or not, why the term calf is used. And it just comes from old words in various languages, related languages. And it just happened to eventually morph into the spelling that you see there. And it largely is plantar flexion and stability of the knee. So strains. So rapid extensive contraction or a violent stretch of the muscle which causes high mechanical stress resulting in varying degrees of rupture within the fibers of the micromuscular tendinous unit. In other words, when something's stretched, you add a contraction, it's really vulnerable. And so during the running, so where it's most active is when it's swinging, so it's being stretched and then it's being contracted, so it's an eccentric contraction, and that's where it's usually torn. But it can also be, you can also get a strain at the late phase when it's in late stance phase. So etiology, when running, same thing. Second half of swing, greatest tension and length. You need a strong contraction of the hamstrings, relaxation of the quadriceps. So one thing that comes up is muscle balance. If your quads are really strong and you're not strengthening the hamstrings, you're more vulnerable. And you want to have good coordination. So a lot of proprioceptive exercises, balance exercises. And the biceps tendon or muscle goes through the most tension. But all of them, they're biarthrodial, articular. Anything that crosses two joints is going to be more susceptible. So that's all the hamstring muscles as well as the gastroc. So biceps femoris, you can feel it on the lateral of the knee going to the fibular head. And like the rest of the hamstrings, they attach right into the ischial tuberosity. So sit upon, arse bone, whatever you want to call it. And but the short head attaches onto the femur. So semitendinosus, and if you palpate medially, it is you can definitely feel it. It is the cord, where the semimembranosus is the one a little more lateral to the tendon, to the semitendinosus. Or I've got them mixed up there. Excuse me. I think I wrote the wrong. Yeah. No, that was correct. Semimembranosus. Sorry about that. A little confusion on my part. So same as the long head of the biceps, it attaches to the ischial tuberosity, and then just goes down to the area of the pes anserinatus. And membranosus, also ischial tuberosity, and it has a number of insertion points. And I found one article that said that there's probably more. So there's 6 different insertion points minimum. And yes, it does get more exciting than this, I hope. Oops. So predisposing factors. Some of these I thought were pretty interesting. And one of them came up from a soccer ref, and that's the last one. So people who are on meds for cholesterol, statins, You see a lot more calf and hamstring tears, people who are taking Lipitor or Crestor. And so that's something to be aware of. And when they mentioned it, I went and looked for some articles on that, and there were some. So age is a factor. Previous injuries all over the place. It could be in the calf, it can be in the hamstring, it can be in the knee, it could be in the ankle, it can be in the hip. A big thing is the lumbar spine and SI joint. So you really want to look, when you're assessing, you want to look at the mechanics of the pelvis. Because if you picture the rotation of the pelvis, well, now you're getting more tension on all the hamstring muscles. Fatigue, muscle imbalance, as mentioned before. Ethnicity, this one was interesting as well. Now, they mentioned that Australian Aborigines and blacks were more, it was more common to have hamstring tears. Osteitis pubis, which can mean that the pelvis is going through a lot of stress. Adolescents are more prone. Dehydration, diabetes, inadequate warm-up, any running sport really. So soccer is a big one, but anything, dancing, but a lot of running sports, soccer, football. So non-predisposing factors. So these things have no impact on hamstring injuries, beekeeping, hermaphrodites, Slinky's tofu, Mrs. Butterworth syrup, but the syrup might because of diabetes. And this one, clinical presentation, pain, tenderness, loss of range of motion, decreased bruising, decreased strength and bruising. You can have a little or a lot, and apparently it gives you a wedgie as well. Now, with complete tears, I saw someone who had a complete tear of her rectus femoris, and she came in, and it didn't present at all like this. She was playing volleyball, and she just went to jump, and she felt a sudden pain, and then there was no pain. So she came in afterwards, and she said, "What are these two lumps?" And I said, "Well, they're not two lumps. It's a hole, because the rectus femoris had completely ripped and gone up towards her hip and down to her knee." So she had no pain afterwards. So it can present, you'll certainly notice with the hamstring loss of function, but with a complete tear, you can have no pain, no bruising. It was very odd. So grade 1, so you just have a few fibers. As you look at it, you can see different articles will say 0 to 10% or up to 10%. Some will say choose different numbers over what grade 1, grade 2, grade 3 is. So I just randomly chose some that I saw. It's pretty variable, and presentation can be pretty variable. So you have a few fibers torn, and it can just be an ache, and you can still have full function. You just get some stiffness in the back of the leg. They're walking fine. They may even be able to run fine. But as you get more fibers torn, then you start seeing function being lost. So significantly more, 10 to 50%. More acute pain, swelling, some discoloration, some function loss. Gait and running are altered. Pain with any palpation, resistance, or stretch. So there's an example of a severe one. You can see the deformity there. So that's anywhere from 50% plus to a complete rupture of the muscle. And so you do see function loss, a lot of weakness, usually severe bruising, pain, swelling, and like that, deformity. So differential diagnosis. You can have, you might want to rule out a number of these. Adductor strains, avulsion injuries, anything going on with the lumbar spine, SI joints, referrals. So it's important to rule these things out. So like doing the slump or anything else, any of the other important tests. Rule PCL tear, that's going to affect the hamstrings as well, because it's going to be pulling the tibia back. Number of things. Assessment. So the first thing is when they felt the injury. Now, most of the time when you hear people mention, if it's severe enough, they're going to notice right away, right when it happens. And, but if it's grade 1, they may not notice until after they're done with the activity. So some of the tests, and I'll have pictures of these, straight leg raise, the Lasag test, do resisted knee flexion, but in a flex position, Aslan test, slump test, drag test, takeoff shoe test, double leg bridge. So all of these are basically just putting tension on the leg and or tension and a stretch. And so they're just variations largely of the same thing. They don't get particularly creative. I find that when it comes to hamstring and calf injuries, just palpating is a really good way to assess it. You want to assess the running and the walking, and then look for bruising, any asymmetry. Again, palpation is a big one, especially when you're looking at the plantaris, because there are no specific tests for that. Look at the range of motion, hip flexibility, again, L-spine, SI dysfunction, and ultimately you can rely on imaging if nothing else comes up. Recently, I had someone, I was like, I don't know what's going on. It ended up being the plantaris. And so the Asling's test, it looks at, it's a test to see if you're able to go back to activity. And you can see the person's leg is strapped down. You can get someone to hold it down, and you 10 times rapidly lift the leg right to the end. And if you're without pain, you can start returning back to activity. The hamstring drag test and takeoff shoe test, it's basically the same thing, only you're on a little more bit of a stretch with the drag test. It's on the left, it's a little bit of stretch, add some contraction, so you're going to feel it there. Just taking off the shoe, you're going to feel that typically if it's a grade 2 or more. And this one is incredibly creative. It just looks like a hamstring stretch. So same thing, hip at 90 degrees, straighten the leg, stretch it out. The plank test, that's just it's not being stretched at all. It's just putting tension through it. And basically you're bridging and holding yourself up with the affected leg. And that's another way of assessing it. Bent knee stretch test, hips at 90 degrees, and then you straighten the leg. Typically, if I remember correctly, women would get from horizontal 77 degrees, and guys on average would be 71, but it's really variable. I had a woman come in who did the splits while cross-country skiing, and she said, oh, I tore my hamstring. I said, oh, okay. So I took her leg, and she went right up to about 150 degrees. And I said, I don't think you have a problem. And she said, no, look at my other leg. And it went past her shoulder. So there's a lot of variability. So you can't rely on these numbers entirely. And so here's another take off shoe and put shoe on test. If you're a parent, you got to be really patient. So this is a patience test. Now, management surgery is rare, and more than 1/3 of people who do get a hamstring strain will do it again within the year. And so you really want to protect the tissue, minimize strength loss. So keep using it, even if all you're doing is walking. Minimize motion loss. And you're not stretching, but you're maintaining a range of motion, keeping it out of pain. And that's a big one with hamstring and calf stretches, strengthening and stretches. Just don't go into pain. Keep it comfortable. And you want to correct gait issues, common things to do: walking, ice, bike, all the usual physio stuff. Some single leg balance exercises are nice and safe to do. Isometric submaximal resistance at 90, 60, 30 degrees, ultrasound, acupuncture, massage, TENS, IFC, laser, taping meds, whatever tickles your fancy. Management, again. So this can be tough just because it's so common to re-injure it. And quite often the following one will be worse. So I found there weren't an awful lot of studies, and some of them were contradictory. They refuted claims of other studies. So there certainly has to be a lot more studying done on this. So some other ideas that you can do: you can wear compression. You can wear, for calf injuries, you can wear a heel lift. Again, meds, ice taping, soft tissue massage, whatever form that takes. That's pretty important, even at the early stages, but you don't have to go into pain. And because you don't want to affect or interrupt any of the vascularization that's taking place there. But as it goes on later on, phase 2, phase 3, you can get pretty aggressive with that. So now, one thing that came up a number of times was just core stabilization. people who did core work did way better than people who didn't. So contractions, stability around the pelvis and low back are really important in rehab of the hamstring. And they did even better when you combine that with massage. So there's the plug for massage. Hamstring rehab, and again, this is pretty variable. Phase 1 up to 3 weeks. Simple things, not really stressing it. Prevent loss of range of motion. Ice bike, isometric exercises. Again, looking at 90, 60, 30 degrees within comfort. Single leg balance, some soft tissue work, and just walking. Next phase, basically up to beyond 2 months. Again, pretty variable. Windmill exercise without weight, and then you can work towards weight. Leg curls on the ball. Let's see, progress to full flexion strength at 90 degrees. And then when you get that, then you can move on. When you've got 80% of your strength, you can move into the next phase. But you want to be basically pain-free with jogging forward and backward. And phase 3, treadmill. You can do moderate to high. Not a fan of high too early, that's for sure. Eccentric training, and we'll get into that as well. Eccentric training was a lot more successful for both calf and hamstring injuries. And so you're looking at core, range of motion, some soft tissue work, and eccentric exercises. And you can move into plyometrics, so doing a lot of jumping exercises, sprinting where you accelerate, decelerate every 5 meters, just kind of sprinting and stopping, sprinting and stopping. Windmill touches with weight and on unstable surfaces. BOSU, sport-specific drills. You get into bounding, split jumps, box jumps, full range motion without pain, full movements and resistance without pain. And oh yeah, here's my favorite exercise. So early rehab, again, up to 3 weeks. Same thing, protect the tissue, maintain range of motion, avoid any excess lengthening and poor gait patterns, all the usual stuff. And again, you don't move on until you have moderate resistance to prone knee flexion at 90 degrees. So here's probably the sexiest Tibetan guy we have in Cloverdale Clinic, showing some of the exercises. So he's just demonstrating isometric knee flexion at different angles. And then you can do some bridging. The bridging is pretty safe to do, contraction in a shortened position, so it's nice and safe there. The hamstrings is a progression. You don't have to fully lengthen it, but focus on the eccentric. And here's some windmill type exercises. And you'd start off without weight and eventually move to some weight. And then the middle phase, you can get into more eccentric exercises and start adding more weight. Anything challenging your balance. The Nordic hamstrings, that's tough. Now, it can also be used as a gastroc exercise if you're dorsiflexing at the same time, and I'll show what that is. But it's a really tough exercise. And with that, you would just hold it as long as you could and then just drop to the floor, and I'll show a picture of that in a moment. And so you also want to really focus on core and increasing resistance and strength. Let's see. Oh, band walking. And of course, some neural flossing. It's important just to keep the nerves moving. Oh, let's see. What else? So here's the band walking. You can go side to side, backwards as well, in a flex, with the knees in a flexed position. Here's an awesome exercise. And believe it or not, this was a real product that they were selling in Korea.
Oh, that's funny.
I only want to see Howard doing this. But
That is funny.
Yeah, I can't believe they marketed this. Some of the stuff, oh my God.
Thank God the seat's on.
Yeah. So you want to move into this phase. Excuse me. When you're having full strength at 90 degrees without any pain. So you want to be able to have no pain with forward, backward jogging, 80% strength, pain-free, max eccentric when in a shortened position. So treadmill, you can go harder. Isokinetic eccentric exercises will show some of those. Plyometric, just a lot of jumping exercises. Again, acceleration, deceleration, shuttle type exercises. Single leg actually course, and then move into sport specific activities. And so here's Tenzing doing deadlifts with the bent knee, and you would eventually move into a straight knee. And then here, the one on the left, what's that? Oh,
How are you, John?
Sorry?
Hi, John, man, you've been so good to me. You know, you send me those things.
Oh, I didn't understand that.
I just muted him. He's talking to somebody else.
Oh, okay. All right. So the exercise on the left is the Nordic eccentric one. And this is a really tough one. It's really good, and it's safe if done properly. So you hold yourself from a vertical position and lower yourself down. And when you can't hold yourself anymore, you just drop. And so you don't try to fight it too much. And as you get stronger, you can go lower and lower. Now you can also, because the gastroc crosses the knee, if you put the foot in dorsiflexion while it's hooked under something, whether a bench, a bed, or couch, or whatever, it's actually a pretty good gastroc exercise, but it's really quite tough. The one on the right is an eccentric exercise. So the leg that's forward is the one that's being strengthened, and you just slide the foot back slowly, but you don't do any concentric contraction. So you just drop, go back up, and slide it back again. So this is getting into the end phase there. As far as stretching goes, initially you just do it within comfort and just within a comfortable range, and then eventually you can move into stretching when things are going well. These are box jumps, and believe it or not, the one on the left was actually trying to jump up there. And she was an American weightlifter. It didn't go so well.
That's about how good I would be at it too.
Yeah, I'd have to wear a mouth guard, I think, doing it. So you can do various heights, just get it higher. You can do single leg. You can do it from a seated position on the floor, and a lot of different ways you can do these. So getting into calf strain. So here's a good picture of, on the right, you can see where the soleus is and the gastroc. And I thought that was just a fun picture on the left where that ankle looks like it's destroyed. Anyway, the most common injury is the medial head of the gastroc. So foot mechanics become really important. So if you're really pronated, you're putting more tension on the medial head. And you want to check, whenever you're getting a calf strain, you also want to check, again, very similar to the hamstrings, you want to check the SI joints, lumbar spine, see what's going on there, because that could be causing the pronation. So the medial head is where most tears, like usual, are at the musculotendinous junction. Medial head of the gastroc, I believe it was 80% of the time is what's torn, and it's usually going to happen eccentrically. So I wrote racket sports because a lot of people that I see with it, it's playing racket sports. Doesn't matter what it is. It could be tennis. It's certainly a lot of Achilles injuries. Tennis, badminton, racquetball, whatever. It seems to be a big one. And it's because they're moving quickly forward, backward, side, and so they'll be contracting when it's on a lengthened position when they're stopping. So the foot's in dorsiflexion, and then they contract to do a burst forward. So they're made up of, the calves are made up of the gastroc, soleus, and plantaris. And so same thing. Oh, sorry.
Colin, go back to that slide. The medial gastroc is bi-articular. What did you mean there? I didn't get that.
Oh, so because it crosses both the knee and the ankle joint, well, going to the calcaneus, it's more vulnerable.
Okay.
Injury. And same with the hamstring injuries, because they all go from the ischial tuberosity to below the knee. They're vulnerable as well. So you see more injuries in biarticular joints.
So is the lateral head, excuse my anatomy, is the lateral head not going to the back of the knee?
Oh yeah.
Both of them?
There it is.
Yeah.
So it does. but the medial head is more vulnerable.
All right.
So
Most commonly taught.
especially with if you've got foot overpronation of the foot, anything going on
Yeah.
in the pelvis. So
Correct.
let's see, same thing, high forces being stretched at the same time with the contraction, quite often with an eccentric contraction. So predisposing factors, almost all the same things as the hamstrings. So, and let's see, anything different there? No, it's pretty much the same thing. A few things removed though. Yeah, Howard, I don't know if you caught that statins. I thought
Yeah, I
that
did.
was,
Yeah.
to me, that's the most interesting. I had no idea there's a higher incidence with statins. So gastroc, there we go, medial head, up to the supracondylar ridge, lateral head, the lateral condyle all goes down to the calcaneus. So it's, because it crosses the knee, it's also involved in stability at the knee, but it's largely plantar flexion and reflection. And soleus, so it's thought to be by far the biggest contributor to plantar flexion, offering 80% of the contracting force through the Achilles. So most of it is attached up around the fibula and medial border of the tibia. It again stabilizes around the calcaneus, involved in plantar flexion or eccentric dorsiflexion. And the plantaris doesn't offer a whole hell of a lot of strength. So you can see the numbers vary there from 7 to 20% don't have one at all, but it's believed to be more proprioceptive. So it's believed to be just a remnant where it's prominent in other animals. But this is where palpation comes in. If you look at the picture, the tendon wraps around medially, so it's all along the medial side down to into the Achilles. But as far as strength goes, it doesn't offer a lot. And there are no real tests for it that I found anyway. So with muscle testing, you can just do it manually, legs straight, pushing out, getting them to plantar flex for the gastroc, and with soleus, 90 degrees, just to add resistance there. Clinical presentation, you can have, well, certainly a lot of bruising taking place with the bigger tears, but initially you may have just a sharp pain, but still maintain function. With the grade 1, grade 2, similar to hamstrings, 10 to 50%, takes about the same time frame. And grade 3, you can have a rupture, pain, swelling, tenderness, a lot of bruising. And again, I think palpation is one of the better things to be good at. Differential diagnosis, medial tibial stress, Achilles, plantar, fascia, and joint sprains, and you can have cramping and Baker cysts, a lot of sources for that. The only test that really comes up is the Thompson test, and that's basically squeezing the calf and seeing if the foot. Other than that, you can just do resistance tests or range of motion tests. So you're just looking for bruising, swelling, decreased range of motion, pain on resistance. But again, look at lumbar and SI and foot mechanics, see what's going on there, because those can be contributing to it. And look at them in standing. You can look at them walking, check range of motion. But again, I rely heavily on palpation with these because the tests are kind of pretty general. And then, yeah, this is an interesting picture. Not sure what's going on there, but gastroc, again, most common is the medial, and most often with eccentric force and contraction. Soleus is inflection, where the gastroc more in extension, and just palpate, it is deeper, so just below the gastroc. Plantaris doesn't happen very often, but I had one recently and found out for sure through ultrasound. Calf strains, again, same thing, all the information I mentioned before. And so similar to hamstrings, ice rest compression, range of motion, bike, no stretching. Phase 2, you can start getting into more resistance, but maintain function and range of motion as much as possible. You can get into soft tissue work, massage, gentle calf raises with both feet, but not put on stretch. And phase 3, you can get into single leg, you can get into all the jumping, running, sprinting, box jumping, sport specific activities, running, and hang in there. And that's my kid showing early stage. She has no idea why I'm making her do this, but you can start with very gentle resistance with the elastic, and Tenzing showing there with more weight to get the soleus with the knee flex, so it takes the gastroc somewhat out of the equation. And there he's showing just calf raises on the step, but not putting it on stretch. And as you get better, you can go lower and lower, staying out of pain, and then progress up to single leg. And then he's stretching, he's just demonstrating ways you can stretch it just on the step or up against the wall. And so you want to progress into bounding, split jumps, shuttle exercise, plyometric box jumps, again, 5-10 meter acceleration, deceleration, sport specific, and of course, prancer size. Those are what you want to progress into. So the takeaways: the muscles that are most often injured are the biarticular, medial head of the gastrocs, in particular. The biceps, hamstring is 80% of the time, it's the one that's injured. Lumbar and pelvic mechanics, those people, if you focus on that, those people generally do better. Foot mechanics as well. So you want to do a lot of core exercises. The eccentric exercises, those people do much better as well. And always pay attention. It's got to be pain-free. And people who get soft tissue work, any massage, do better as well. So, and then you can go into progressive agility exercises. And that's it. Now, all right. I whizzed through that. So any questions, or anyone want to add anything there?
I would like to ask one question, Mr. McGowan.
I'm straight, everyone asks.
But I'm not asking you to answer it because I know you know the answer. I want to know from everybody else, if somebody comes in with a calf strain,
Yeah.
and they got a little bit of sweating and they got a bit of pain, what, and we unfortunately don't have it at our clinics, but what product would you advocate them to get that is most successful in controlling the swelling, the pain, and just help with a little bit of gait? What would the product be in your experience?
Well, outside of our alcohol, I guess what's sold within the clinic.
No, I'm not asking you to answer. I don't want you to answer. I want them to put it on the chat or answer. Okay. Just tell me what they think.
Roller
All
stick.
right.
A what?
You know the rolling stick?
No.
But it can be done.
Of course it can be done, but I asked you a question. I said, what product could you put on to these injuries that will help with the swelling and the pain and the gait? A rolling stick will help to break up the scar tissue and loosen up, but that's not my question. I'm asking you in the initial day one visit.
Is it the tensor machine?
The what machine?
Tensor machine?
What's the 10? What's that?
The TENS machine.
TENS.
No, this is what they can actually take home.
That's sold at the clinics.
That's not sold at the clinics. I mean, physio cream would be ideal, but that's not a product. It will help them, physio cream, 100%. But this one's not sold at the clinics. What do you think it is? Having done, correct. Now, when you get a neoprene compression sleeve for the calf and the hamstring, it's unbelievable. That slight compression, how it helps with the bruising, the swelling, specifically the swelling and the pain, and enables them to walk a little bit easier. Unfortunately, we don't sell them at the clinic, but really, to be honest, if they had to have that and physio cream, It does wonders. And I don't know if you know, most of you do. I worked with South African soccer team and provincial soccer team most probably 10 years. And they thought I was so good. I wasn't good. I just knew what to give them. And that really, especially in the grade 1 and 2 zone, it was unbelievable. Now, I just want to make one comment and then I won't say anything else. The best, Colin said that there's some methods of, testing it, like the calf tear to check that there's no Achilles tear. I think he spoke about the Thompson test and everything. Yes, there are lots of tests, but I can tell you now, and you heard him say that the medial gastroc is more vulnerable. The best form of diagnosis for all of this is basically your palpation. But the palpation, what I'm talking about besides your active movement, is the pincer grip. Because if you get somebody lying prone and you just, with your pisiform or with your fingers rubbing the back of the calf, you're going to miss a lot of sometimes the medial aspect. So when you get that pincer grip like this and you go down on the inside, then you do the whole calf, then you turn around and do the outside, you will never miss anything. And the same thing you can do for the hamstring. The pincer grip for the whole thing, and then get them to do an active movement at the same time if you can't pick it up. I have found, even in terms of the Thompson test, it's a similar thing, obviously, when you palpate the calf muscle, but when you compress and squeeze gently in a zone, I find it much better than straight down compression, which often misses the strain or the tear area. So that's just from my experience, that the palpation is the most effective in the diagnosis. Besides, I'm not saying don't do your others like look and see, see and move and special tests by all means, but those work the best. I'll leave it to you, Colin.
All right. Anyone else? Any questions?
I had a question, actually. I know this has been popular, the whole idea of like prehabbing for hamstring strains. And I know stretching, apparently the evidence kind of was questionable on whether stretching helps to prevent like strains, and at least in the Achilles tendon. Is there evidence to say that like doing strengthening proactively can reduce the risk of a tear of like the Achilles or the hamstring that you're aware of?
Yes. Like at the beginning, mentioned imbalance in muscle strength. And if you say your quads are really strong and your hamstrings are weak, you really want to focus on having good hamstring strength. Otherwise, say you're running, once the leg is extended and that the hamstring has to contract eccentrically, if it's weak, it's more vulnerable. So yeah, you do want to, when you're looking at sprinters, they focus heavily on hamstrings. They do a lot of work on hamstrings.
And then how often do you recommend that they train? Is it like a once a week kind of thing or twice a week? Like, how do you tell them to go about it?
God. Well, if I was at that level, I would be training it every day to a certain extent, but focusing on it maybe twice a week, just depending on what the activity was.
I think in pre-season training, they do it quite often to build up a level of strength. And then, as Colin says, during the season, they want to maintain it maybe twice a week. But in the pre-season, you want to really build the muscle and condition, and then you want to sustain. But the answer to your question, which is a difficult question, stretching, strengthening, I believe 100% muscle imbalance, Colin, spot on. But the big thing is stretching. And I think that a functional warm-up today is more important than stretching. However, if somebody's got a specific problem of a specific tissue, then I think both, the stretching and the functional warm-up. But they've shown that I think functional warm-up and doing certain activities that make up the activities that you're going to replicating in your sport are the best, because it moves the joint eccentrically, it moves the muscle eccentrically, it moves the joint through full range, and it does that whole segment of multi-segments. As you heard him say, some of these muscles cross two joints.
Yeah, just looking at some of the things mentioned. Roller stick, physio cream, ice pack, K-tape, and Catherine's asking about compression sleeves. Should we be selling them at the clinics, Howard?
We should, but if people don't know about them, much like the Lysine ball, which we sell out of Cloverdale most probably every 2 months because we get such good results, I think I'd rather they send them to whoever they want to get them, because until people start believing in what works and what they do, we're not going to stock products. They all know that physio cream works because patients ask for it. The trigger point ball works because it relieves the pain. So does the lumbar roll, and so does the Lysine ball work. But you have to have a little bit of experience with a calf sleeve. And because there's different sizes, normally the most common is medium and large. So it's not too bad. So we can maybe stock 2 at each clinic, but we can't stock, the whole range of all of them. But I can just tell you now that when you give a patient a calf sleeve, they come back and they're very happy.
And just thinking of physio cream, after I had an accident in 2014, I had bilateral frozen shoulder, and I was given diclofenac for my shoulders, and honestly did nothing. And so when I used the physio cream, I didn't know we were selling it. I thought, and it was way better than prescription. I thought, my God, this is so much better. Where do they sell this? And I just looked online, and I thought it was pointing at Shoppers Drug Mart next to the Cloverdale Clinic, and asked Zini, and she said, no, it's sold here. What? Okay. So it was pretty effective.
Yeah.
Much more effective than diclofenac.
The one thing we didn't speak about, I don't know, unless I missed it, and maybe we can ask some of the people in their field. Did you mention anything about IMS or acupuncture for the treatment of this?
Yeah. I went.
Maybe they can comment on when they feel they would want to do it, like in the acute stage, after how long, or how they would do it, because that would be interesting. I don't do it. I used to do acupuncture, so I can't talk about it.
Yeah, you can make an argument for doing it at any phase. So,
Mahir, what's your point of view for that?
So when it's like an acute injury, and if there was bruising, then ideally you shouldn't be doing until the bruising goes down. And you want to wait until the first phase of healing has happened. And then if it was a minor calf strain or hamstring strain, then you can do it at an acute level. And I do the E-stem version of it, but I know some physios would do the natural version where you twitch and piston. But technically, it depends on the level of injury. So subacute is what is the ideal way to do it, in my opinion. But
now, are you talking?
There would be some other people saying differently.
Are you talking about needling directly into that area?
No, so you wouldn't go directly where the strain is. It's better to get some contractions on the up. Like, let's say the strain was in the middle of hamstrings, right? You would try to get some fibers on the top and some fibers on the bottom.
Okay.
No, not on where the actual strain happened. That's something I would highly not recommend.
Yeah.
And in the calf, I've always found that whenever there's a calf strain, needling soleus helps more at the initial stages, and then eventually adding some needles in the calf. But the E-stem version is a very minimal contraction going on, and it's not like pistoning effect where there is a lot more powerful jolt to the muscle.
Yeah, because I've found that with some injuries like the calf, also remember when you do the pincer grip, a lot of calf injuries may include the tib posterior muscle, which I find when you lie them on their side and you do the pincer grip massage, or you massage it with your this hypothenar or whatever, thenar eminence, whatever it's called there, that really gets to it. But what I found, why I mentioned this, is that when I'm struggling and it's more the end of the subacute, and there's just 1 or 2 spots that are not responding, but there's an 80% improvement, but I just can't get that last 20%. May involve the tip post and a little bit of the borders of the medial gastroc. When I refer to this acupuncture or IMS, I find they get that last 20% for me. So that's what I just want you to make you aware of. And also, just remember the pelvis. If the pelvis is weak, specifically not aligned, and the muscles of the glute med max are weak, you're going to have internal tibial torsion, and that results in pronation, and that results in continual stretching of the calf. So you have to think, is this person pronating, or is their foot mechanics not right? And how's the stability across the pelvis? And the hip abduction and a little bit of lateral rotation is vital to strengthen with hamstring and calf injuries. And then Colin mentioned one that's very important. Often with a medial hamstring injury, the adductor muscles involved, and often it's missed. And just from practical experience, after having done thousands of these with the teams I've done, the adductor is a common one that's missed. And also remember, when you're doing the calf, the tip post, and also the origins of the where it inserts behind the knees, and also the popliteus, because that whole fascial area gets tight and gets involved. So don't forget to look at that. And if you're doing a calf, look at the hamstring and the glute. If you're doing the hamstring, look at the pelvis and the calf. Don't forget that, because it's the lower kinetic chain, and that sciatic nerve mobility must always be looked at as well.
And I would like to add like one thing about shockwave therapy, because I've done a course on it. They do say that if you do shockwave therapy beyond 3 months for all athletes, you can achieve like 70 to 75% success of if your pain is existing beyond 3 months.
Yeah, that's a good point.
Yeah.
So, the last thing, I'm sorry to do this, but this is my area, as Colin will know, we chat about this often, for bruising. If you want your patients, you think you magic, the sleeve we've spoken about, the kinesio tape, I'm telling you, you put that on where there's a lot of bruising on the calf and a hamstring, and they come back 5 days later and they think, or 3 days later, and they think, what's happened? Honestly. So I know this is detailed what Colin spoke about, and he went through this in detail because he has to share all these important things. But take away some practical things today of what he said, of the differential diagnosis, of the other muscles that are involved, and of these practical things we've just spoken about, because this is what's going to make the difference. And also the services and treatments that are available, from added on products we spoke about, the acupuncture thing, the kinesio tape, these, and then shockwave. These are things that we have access to, that you must think of this in a big picture if you're struggling. Sure, if they all get better within 2-3 weeks, you're good to go. But it's just nice to know in your treatment plan that the patient knows you've got a lot of these modalities at hand within Allied, and you're more than likely going to help them.
It's just to add to that, where you put the tape, the bruising disappears in that area. It may remain around it, but it just disappears where the tape is. It's kind of interesting. Yeah. All right. Anything else? Anyone else?
Any other questions? Again, you guys can hop on mic, or you can pop it into the chat box there too.
Let's have a question from one of the kinesiologists, because let's hear from them where they do well with their rehab with hamstrings. We've got a couple of kinesiologists on here, I see today. Here's your chance to get people to know what you suggest. So who am I going to choose? Am I going to choose Raphael or Nadia? Who wants to go first?
I have to pick them, Howard.
All right, Colin, you pick one of them if they're available. Let them tell us what they found successful.
All right. I worked with Tenzing, so I'll pick on Tenzing.
Right, let's hear from Tenzing.
If he's still there.
Sorry, what was the question?
So the question is, how do you rehabilitate your hamstring injuries after the subacute phase? What do you find is the most challenge when they go, like is it their strength, their functional strength, the plyometrics? Where do you find you've got to give them, most support where they struggle?
Yeah, usually the strength.
In what aspect of the strength? Are you talking about, functional strength, or just basic movements with TheraBand? Where do they sort of struggle to progress?
Can you ask that question again? Sorry.
Let's say you've given them some strength work with a TheraBand.
Okay.
Just basic movements like knee flexion or hip abduction.
Okay.
Then when you have to start doing diagonal patterns or weight bearing on one leg and doing things, where do you find the biggest challenge where you have to go a little bit slower for these patients because they struggle a little bit?
Usually their balance and stability a little bit. Yeah, so just like, doing some single-legged stuff and yeah.
Yeah, so that's very important. I mean, balance and stability tell you that if they haven't done the fundamentals of that stabilization across the core and their hip abductors, adductors, flexors, and extensors, they're going to struggle with the lower limb kinetics. And that's why it's important to understand that the patient has to work through those different parameters of stability, strength, functional strength, and then plyometrics and return to sport. That's the exact reason why it's got to be progressive. Back to you, Colin.
All right. Anyone else? Oops. Right. If not.
Okay, thanks everybody. I'll stop the recording here. If I can figure out how.